There we go. I am going to stop my screen share. Hi, everybody. For those who have not met me, and I have not met yet, I am Amy Bucata, AAOM's Executive Director. I joined the organization in December of last year. And as I was saying early on, I am thrilled to see the number of people who have accepted our invitation to be on the call tonight. And I'm thrilled to see the number of people and the activity and the energy surrounding AAOM's business and what we're up to. And excited to share tonight that we have 3 events on the schedule currently that I want to share with you. One is our upper and lower extremity cadaver lab, and that is in Novi, Michigan on August 19 and 20. The next, well, other than the other hot topics, the next big one is a Rotan mission in October, and our AAOM 2024 is on the schedule for March 13 to 16. We are not giving away the location of that meeting just yet. We're running a contest, and you can find all of this information on AAOMED.org under the education tab. With all that being said, I am going to pass the baton on tonight. David, let me see if I can find where you are on my list here. To David, who is going to be our speaker for tonight. I'm going to make you host. There you go. And again, appreciate everybody joining us.
Hello, everyone. Thank you for taking time out of your evening, and I'm, honored and to be able to speak with you today about. We're going to be talking about epidural PRP and comparing it to epidural steroid. Let me just pull up the presentation. Oh. So my name is David Itskevich. I practice in the DC area. I work with John Farrell, and I do a lot of the different spine procedures. My primary specialty is physical medicine rehabilitation, and then I did a pain medicine fellowship at UPMC, and then I came to the DC area. I've been with a group for 6 years, and over the course of that time, have done a lot of different kinds of fluoroscopic guided and ultrasound guided procedures, orthobiologic, hydrodissection procedures, all different kinds of treatments. And I wanted to present this specific case about a really interesting case that we'll get into. A certain patient who had an epidural steroid injection for radiculopathy, and then had epidural PRP, and very different results. But let's get into that. So I have no financial disclosures. First, we're going to go over an anatomy review, very basic. This is, you guys know all this, but we're going to go over what's in that epidural space, and then can PRP help nerves? A very basic review of PRP's effects on different nerve injuries, and what does PRP do for ligaments? Those are the 2 key structures in that epidural space, which we'll get into. Then we'll go through the case report, we'll look at the MRIs, and also kind of touch on some other cases where we had some success using epidural PRP. So here is a basic slide showing axial lumbar spine anatomy. And I put this here just to review. When we access the epidural space and we put something in there, whether it's steroid, orthobiologic, whatnot, What is that? What do those platelets come into contact? So there is the ligamentum flavum posteriorly, you have the epidural fat, you have the nerve roots that are exiting, you have the dura. So, there's evidence for epidural PRP for post-dural puncture headaches. There's also the ligament in the front, which is your posterior longitudinal ligament that sits right behind that disc. And that's such a crucial structure because for patients with disc herniations and lumbosacral radiculitis or radiculopathy, you have this ligament that sits there in the front of that epidural space that has these two layers, a strong, thick, deep layer and a superficial layer that kind of fans out and is continuous with the annulus fibrosus. And it is supposed to protect those nerves from being compressed, getting irritated by any kind of disc injury. And, what does PRP do for nerves? There are different studies looking at PRP for different kinds of peripheral nerve compression type of injuries, such as carpal tunnel syndrome, multiple studies, even systematic reviews showing improvement, especially in mild to moderate carpal tunnel. There's one randomized controlled trial that was published in Pain Medicine Journal on perineural PRP for diabetic peripheral neuropathy. So I threw that in there too. And there was actually there have been several studies looking at epidural PRP case series. There are 3 randomized controlled trials, and there was a great systematic review that was published in 2022 by physicians from Mayo Clinic, really compiling all the data at that time and showing that multiple studies have shown, even though there's a lot of variability with that, with the platelet composition, all that platelet lysae, PRP, generally there is improvement, and a lot of the studies show that it outperforms steroid with a longer, greater benefit. Some of the studies actually show MRI evidence of improvement as well, and most of the studies looked in the lumbar spine, but some even showed improvements in the cervical spine as well. And then why do I go through this? Because I think the main 2 structures in that epidural space that really the platelets improve on is the direct effect on the nerve roots, as well as these ligaments that are there, including that posterior longitudinal ligament. So what does PRP do for ligaments? In terms of studies, it kind of mixed for ATFL injuries and UCL injuries. For ATFL, some studies show improvement, but they actually, several of them have shown when you look long term, patients do about the same as conservative care. UCL studies in overhead throwing athletes, there is some variable outcomes as well. Some studies show improvement, greater rate of return to play, especially in type 1 to type 3 injuries. But some show about the same rates of return to play as conservative care alone. And then when you look at what kind of effect PRP has, platelet-rich plasma has on ligamentous tissue, it does increase fibroblastic anabolic activity. That means increased cellularity, increased collagen production, and vascularity. And then what kind of effect does steroid have on ligaments? Because we know that this is very well known, and you guys probably, a lot of people here probably talk about the effect of steroid, how it's tenotoxic and chondrotoxic, but with ligaments as well, even though ligamentous injuries might get some symptomatic relief in the short term, but it decreases fibroblastic function and collagen synthesis. It causes smaller cross-sectional area, decreased peak tensile strength, decreased load to ligament failure, so not so beneficial. So the case here, 39-year-old male, right-sided low back pain, that's radiating kind of into the gluteal posterior hip and lateral hip region. No inciting event, aggravated by prolonged sitting, lifting up his young child, alleviated with standing, lying down, rest. He's tried multiple conservative treatments, which only provided minimal relief. No midline tenderness, no step-off deformity on the physical exam, increased symptoms with flexion at the waist. There was some EHL weakness on physical exam. Other myotomes were intact. Sensation was grossly intact. There was a positive slump sit and cross slump sit test, caused that gluteal pain. An initial MRI in 2020 showed an L5-S1 disc protrusion, contacting the S1 and possible L5 nerve roots in the lateral recess and neuroforamen. So here's an axial image of that MRI showing narrowing of that neuroforamen as well as pressure on that S1 nerve root in the lateral recess. This is before an epidural start injection. And here's that disc herniation you could see on T2 sagittal image. Okay, you really kind of going back there. So first procedure, we tried an L5-S1 and S1 dorsal sacral foramen epidural steroid injection. And you can see the contrast dye on the left with the S1 dorsal sacral foramen extending superiorly to cover that L5-S1 disc. And then you don't see the needle on the right one. Actually, we had a radiology tech training that didn't save the image, but you could see the contrast dye. Throwing the radiology tech under the bus here, but anyways, contrast dye pattern at L5-S1. And the results of that, 60% improvement overall, functional improvement, symptomatic improvement of radicular symptoms. But when we look at the follow-up MRI, the disc herniation actually looks bigger. So despite symptomatic improvement, structurally things looked worse, and his symptoms started getting worse, as typically epidural start injections do. They don't last forever, but kind of what we were talking about before with the toxic kind of effects of steroid on ligaments, makes you think, what does this do on that posterior longitudinal ligament that's supposed to hold that disc in place? And here you see that on axial, things look a little worse. Sagittal, things look a little worse. You have not just this posterior kind of disc material, but now there's some cranial cephalad migration. And so second procedure we did was an epidural PRP. We used leukocyte-rich M-site prep, final volume about 4 to 4.5 milliliters that we divided into that same S1 dorsal sacral foramen and at L5-S1. And you could see that the contrast kind of covers from above and below that disc injury. And basically what I usually do, I like to really concentrate my platelets. So, with a 60 ml kit, if we have like 54 mLs of whole blood with 6 cc's of ACDA, for instance, that would, and you're concentrating it down to 4.5 milliliters of concentrated platelets, assuming a high yield of platelets, that would be a relatively high concentration of platelet-rich plasma. Yeah. So results of that procedure: 70% improvement in low back pain, complete resolution of radicular symptoms, and interval decrease of the size of the disc herniation. That's what the axial image looks like just less than 3 months later. And the sagittal image, it almost looks like that disc material is like flattened pushed back in. And I hypothesize it's because of, I don't think this is just natural disease, progression. I think this is more the actual benefit of the platelets on that posterior longitudinal ligament. Because again, when we go in there, ligamentum flavum, posterior longitudinal ligament, the nerve roots, directly on the nerve roots all get exposed to those platelets and those growth factors. So what we can see is that kind of improvement. Other examples of success with epidural PRP, lumbar spinal stenosis. I've treated several patients with even severe lumbar spinal stenosis with resolution of their radicular symptoms, weakness, the myotomal weakness, pain with prolonged standing. They can tolerate walking greater distances. Here's a patient with a 62-year-old male with a severe left L405 stenosis, and couldn't walk more than 20 minutes. His son goes to UVA, kind of a University of Virginia, very kind of hilly campus. And after the treatment, 3 months later, he could walk all day without having to sit down at all, any pain. And that's the lateral, and that's the AP. And you could see how narrow, as soon as we did like a kind of a left parasagittal technique, interlaminar approach. And you could see as soon as you get into that epidural space, most of the contrast eye goes straight out the neuroforamina. There's such significant narrowing, and you could see towards that left side, that disc space narrowing is significant compared to the right. But he had great results. And then even after discectomy, laminectomy, discectomy, I've had patients that have had improvements. Here's a patient, hypermobile, so you know that they're going to have loosey-goosey ligaments, to use the medical terminology. But so that posterior longitudinal ligament is going to be weak from the start and more prone. This patient was more prone to developing disc herniations and actually had 2 surgeries. He re-herniated twice. And this, he had like actual re-herniation and compression of the nerve roots. It wasn't like just a chemical radiculitis that sometimes we see after discectomy. You remove a chunk of the disc that's coming back, and sometimes there's leakage or extravasation of the nucleus pulposus, this immunoprivileged tissue that can cause this autoimmune effect on the nerve roots. That's not what was happening here. He just kept, I think, with his hypermobile history, he just kept re-herniating. But when we did epidural PRP, that's on the left side, and that's on the right, complete resolution of his symptoms. And here's a patient with a cervical radiculopathy, even after ECDF, anterior cervical decompression fusion at C4 through C6, even after surgery, always had brachyradialis weakness and wrist extension weakness and shoulder pain and tingling in those first 2 digits, and that never proved. But we did a epidural PRP interlaminar approach, also left parasagittal. That's the lateral. That's the AP. And even like 2 years later, full myotomal strength, resolution of symptoms. Here are my references, and thank you very much.
Great job, Dave. Thanks for taking the time out and kind of sharing some of these kind of cases with us. For anybody who has any questions, please put the questions in the chat, and we'll kind of moderate through that. So the first question that kind of popped up, Dave, someone said, so you're surmising that PRP works by strengthening the ligaments around the spinal canal. If so, then why would this work for the second case when the patient has spinal stenosis?
So my theory there is some of the stenosis is because there's a part of the disc bulging back. Some of it is facet joint hypertrophy. Some of it's ligamentum flavum hypertrophy. Facet joint hypertrophy, I'm not assuming that is going to, PRP is not going to magically make bone go away, but the direct effect on the nerve roots with the platelets, as well as maybe some of that disc material can maybe push back in by strengthening that posterior longitudinal ligament. Maybe, and again, this hasn't been shown, and there's plenty of more research necessary in this field. But maybe some of that ligamentum flavum hypertrophy, that thickening decreases with the platelets as well, because that ligament is struggling to kind of hold things upright. So that could provide a little more space, and I've seen a little bit more space in the neuroforamina in a lot of recess with some of these patients. And for the patients that really have like a collapsed disc and that facet joint hypertrophy, then those patients tend to get like a year and a half of benefit, but then their symptoms start to come back, in my experience. But the patients who, but there are patients with, again, severe stenosis, central neuroforaminal lateral recess stenosis, that get relief and have had relief even with one treatment 5-6 years later. So, yeah.
All right. And then another question that kind of popped up in the chat is asking, is there a difference between PRP versus PRP lysate when you're doing epidurals? And then I think along that same line, looking at PRP intradiscal versus bone marrow intradiscal, do you have a preference, or, why do you choose one versus the other?
Great questions. So with PRP versus platelet lysate, I think, I personally think that if there's injury to those ligaments, you're going to have exposed collagen. Those platelets will activate and do their own thing, allow the body to kind of go through that healing process on its own. But there could be an advantage to platelet lysate or releaseate if you use something to activate. Then maybe there's a bit less inflammatory kind of symptoms post-procedure, but I'd prefer to use PRP, in my own opinion, because I want all those platelets to activate over time in that injured area. If you do releaseate or lysate, how much is activated, how much is lysed? Are we really getting all of the growth factors out of there? I don't know, but I know if I inject all the platelets, then the patient's going to get all the growth factors that are within those platelets, assuming they're all going to activate. Regarding intradiscal PRP versus BMAC, so actually that patient case, the patient had complete resolution of radicular symptoms and then had persistent low back pain. We followed up. Now, after I saw about 3 months post-procedure that disc material kind of pushed back in, and in my mind, I think that environment posterior to the disc has improved. So if I go in and access that disc and inject concentrated platelets, pressurizing that closed system by adding volume, then we're it's kind of safer, really. So we did that, and he has complete resolution of his back pain too. I didn't include that in the because we're talking about epidural PRP, but I mainly do intradiscal PRP because there's a lot of evidence to support it. I mean, there's evidence to support intradiscal BMAC. I personally, when Dr. Navani presented at the Toby conference, that randomized kind of comparable trial looking at intradiscal BMAC versus intradiscal PRP, 1 year results of both groups improved, but no in-between differences. And patient tolerance of getting a blood draw versus extracting bone marrow and processing it. And then when I heard Dr. Lutz talk about 21 cases of discitis, 20 out of the 21 cases being BMAX 1 out of 21 cases. Being bone marrow, I know it's kind of like sexy, if you want to call it, doing cellular procedures, and I'm all for getting the patient better, but I usually start with the intradiscal PRP, and then if there's if there isn't the improvements that we're looking for, then you can consider bone marrow. I mean, some of the things that maybe are changing my thinking is Dr. Etleri's study with it's a very comprehensive BMAC to like everything within that lumbar spine, the epidural space, the intradiscal facet joints. I mean, we try to be very comprehensive also at Rossum. Not pitching like a little advertisement here, but we try to be comprehensive here because I use a lot of ultrasound. Actually, I don't just jump to, not everything is a disc, nerve root, facet, and that's it. I really try to focus on a lot of the ligamentous structures, interspinous ligament, iliolumbar ligament, thoracolumbar fascia. I usually test a lot of the different fascial areas, like with Dr. Fullerton's thoracolumbar fascia, that epaxial versus hypaxial versus appendicular fascia, looking at the different weakness patterns that are necessary. You know, you need those muscles intact to support the lumbosacral spine. Look for those injuries and treat that first. In my mind, you want to work kind of from the outside in if you need to. This is such a long, drawn-out answer to your question, but basically, you don't want to ignore those structures, those supportive structures around the spine. And I don't just kind of blanket, carpet bomb everything. I really try to do a diagnostic exam and then really target what actually appears sprained, injured, torn. And then once you optimize everything around, then I go and if there's still an issue with the disc, sometimes it's just a disc injury. I do see that. You push on everything and you look at everything under the ultrasound and everything looks great and you can't elicit pain. But it's, a radiculopathy or an annular tear in a disc. And that's where you need to go. But we try to look at everything kind of pretty comprehensively.
Well, this is AAOM, so this is the home of comprehensive prolotherapy. So you're probably speaking the language of a lot of people.
Don't throw things at me, but I do try to do a comprehensive approach, but I don't target everything. If it looks okay, if it's non-tender. I don't always just target everything, but I might be wrong, and I'm all for improving.
Yeah.
Yeah.
Well, the next question was asking, have you ever done PRP as a caudal epidural, or have you only done it as the interlaminar approach? And if you haven't done it, what are your thoughts on PRP caudally?
So we do a lot of caudal D5W in the office because it really helps desensitize those nerves, and sometimes we even get myotomal improvement. But the issue with that treatment is you really need to do a high volume to really get it up to L5S1, really L4, L5, and it can be very beneficial. Caudal PRP, when we're doing caudal D5W to drive it up there, we're looking at like 15 to 20 milliliters of volume, as opposed to caudal PRP, if without like compromising concentration of those platelets and really making sure we have the right effective dose. Yeah, so we're talking about platelet dose, and that matters a whole lot that we're finding in the literature, right? But in my mind, if you really have to dilute down all those platelets and they kind of spread out through that epidural space, then that region of the spine gets a lower relative amount of that platelet dose. So I would much rather keep it much more concentrated and do interlaminar or transfemoral approach, fluoro guided, than ultrasound guided. Sometimes I've done for some patients, like kind of like a paravertebral transfemoral ultrasound guided approach, but still you're looking at lower volume than doing a caudal.
Right, yeah, and a lot of that's based off of Alicia Schmeigel's, data for the D5W and the caudal, and she's, started off with 10 cc's and now it's up to 20 and sometimes even more. Now, do you ever sometimes start off with a D5W caudal before doing a PRP and an interlaminar?
Sure, especially if I'm doing like a lumbosacral prolotherapy, I often add the D5W, especially if there's a radicular component, or even if not, and we're thinking there's some sort of discogenic pain in that posterior longitudinal ligament, for instance. It gets innervated by the meningeal branch of the nerve root, also known as the sinovertebral nerve. So flooding that area, maybe some of that D5W, that D5 blocks some of that or desensitizes that, less substance P over there, and less back pain. Because the studies by Dr. Smigel showed, low back pain and leg pain improvements. So why not?
Well, just on that same path, these cases we're looking at kind of the the epidural PRP. Once you take a step back and before you get that epidural PRP, what is your typical protocol on handling some of these kind of chronic low back patients?
So I often examine them and look at their for myotomal weakness and some of these myofascial weakness patterns, any kind of signs of instability in their sacrum and their SI joints, because if the posterior SI ligaments, sacrotuberous ligaments are sprained, you're going to have more of a sacral nutation, and you're going to have more lumbosacral compression, right? So even just treating that area, the back of the pelvis, right, it just posterior to that, our center of gravity, our center of mass, can have indirect effects on the disc. So biomechanically, so I often look at those ligamentous structures, really look at that, for instance, sacrotuberous from the inferior lateral angle of the sacrum, all the way down to that ischial tuberosity, really the connection to the proximal hamstring. And anywhere it's injured, anywhere it's tender, I can see that, I can got a needle there and treat it. Posterior SI ligaments as well, iliolumbar ligaments, all that. Facet joints, all that can be done under ultrasound in the office, and I try to do that, minimize the radiation exposure to the patient, minimize cost to the patient. So I try to do that first. Interspinous ligaments, supraspinous ligaments as well. And then sometimes I've been surprised where just treating that alone, I had a patient, John, I think you actually sent me a patient, traveled from like near Richmond, Fredericksburg, Virginia, who had like severe stenosis, radiating pain down her legs. And I did this comprehensive prolotherapy. One time, I'm talking to her about epidural PRP, maybe intradiscal, this and that. We did one prolo and all of her radicular symptoms improved and all of her back pain improved. I was, I'm still amazed, every day with some of these results. And she wanted to follow up. I'm like, don't bother with driving with the crazy 95 traffic. You're doing better. Enjoy life. And she was like in her 80s, and she responded so well to prolotherapy. So yeah, I mean, you don't know 100% how somebody's going to be, how they're going to respond until you try. So why not try the less invasive approach first? And any way you want to treat those supportive structures around before you go and you want to optimize that support structure before you go to the deeper, like disc and epidural space and all that.
Yeah, well, selfless plug for AAOM and some of our conferences coming up. You're hearing that, comprehensive prolotherapy can do wonders for a lot of these patients. And, these, discal and epidural PRPs may be some of the newer, sexier things. But, if you have the basic skills to do comprehensive prolotherapy, you're able to help a lot of people out. And so I think it's so important to have that, in your bag of tricks to kind of treat your patients. One of the next questions was asking, after epidural PRP injection and symptoms decrease, but not clear, would you repeat a second epidural PRP or would you combine another treatment with it?
The only time, I'm not bragging here, I'm telling you honestly, I swear, but the only time I've repeated epidural PRP was if somebody re-injures their disc, because even after surgery, somebody gets their rotator cuff repaired, you can always re-tear it. Labral tear, you can always re-tear. That is one of the instances, or that severe spinal stenosis, where they get like a year and a half of relief, and then they come back and their symptoms start coming back. They don't want it to get as bad as it was, really limiting their function, and then we repeat the procedure, and they're happy because they don't want a multi-level decompression fusion. So those are usually the ones that, but I think that there was something published by, I think, Dr. Centeno about repeating epidural platelet lysate and the percentages of um, improvement increased, like the number of patients that reached 100% improvement increased with repeated epidural PRPs. So there is something out there that actually, if need to, I usually wait 12 weeks before I consider repeating a PRP, because usually my patients only start noticing improvements about 6 to 8 weeks later after PRP, and they can get incrementally better for at least 12 weeks post-procedure. Now, that's not everybody, but I'd say that's the majority of what I see. Some patients, are more the exception than the rule. They only start noticing improvement at 12 weeks. Some start noticing improvement, pretty soon. If they start noticing improvement pretty soon within the first 2 weeks, I usually tell them that's not the healing reparative effects of the platelets. That's more like the endorphins and enkephalins and some of the other granules within the platelets. If they have, a good tolerance for pain, and they have upregulated some of those molecules that decrease pain, and those get released just like the growth factors, and that's kind of the pain relieving effects of the platelets. So I tell them, even though you feel better, don't go crazy. Don't just go doing box jumps and stuff like that. So but about 6 to 8 weeks later is when they really get the improvements from the actual reparative effects, the proliferative and then remodeling effects from the PRP, and it gets better and better afterwards.
Awesome. The next question was asking, do you add ropivacaine to your PRP epidural, or do you just inject pure PRP? Any concerns for pain and increased inflammation with those?
That's a great question. So I personally don't use ropivacaine, or I sometimes mix it with a little bit of lidocaine, tiniest amount, almost homeopathic dose, that just to take the edge off, because this PRP, it can be pretty caustic. It can feel like there's burning, throbbing afterwards. And I warn the patients, especially with cervical epidurals, sometimes they can cause this kind of neck pain and upper back, even sometimes radiating into the chest. It always goes away. It like kind of goes up and then it tapers down. And even in the post-op area at the surgery center where I do these procedures, by the time they leave, they're feeling great. They're doing fine. All those symptoms are gone. All they're feeling is not even the needle poke procedure yet, needle poke soreness, because the lidocaine is still from the sub-Q and skin anesthesia that I do. But I don't mix ropivacaine wherever I'm injecting in nerves, because I just don't want to risk, if they're very sensitive, I don't want blockade for like 6 to 9 hours. The other thing is with cervical, I also don't want to, I've never had a dural puncture, but thankfully, but if you do theoretically inject anesthetic into, thecal sac, and I don't want to cause any of that kind of high spinal blockade. So I don't do that, but call me chicken if you want to, but whenever we're dealing with nerves, I try not to use much anesthetic. If it's very sensitive to the patient, maybe we can add a little bit, but I try not to. Other structures, like a hip, we're treating an anterior hip, I'll try to do a little nerve block, for instance. I can't really do that so much in the spine, but like, you can block suprascapular for the hip. You could block the articular sensory branch of the femoral nerve for if you're doing an anterior hip labrum joint. You can't the spine, you can't really. I mean, unless I'm happy to take any suggestions on how I can improve. There's a lot of people here. I'm pretty flattered, but yeah, I usually don't for the nerves.
The next one seems to be a little bit more of a comment. It states that I commend you, Dr. Itskevich, for your efforts to expand observations made by Dr. Charlie April and a few neurosurgeons who noted at ISIS 25 years ago that if a disc herniation bled or had concurrent hematoma, the disc resolved without a need for surgery. Many anesthesiologists have noted that if they had patients with chronic back pain, they would get improvement if they had a blood patch or for post-spinal headaches.
Yeah, so I'm a member of SIS too, and I'm a member of AAOM, so Dr. April, that was pretty actually another pain doctor, Gabor Rox, was actually the one who kind of brought that idea in my mind, that posterior longitudinal ligament, because he mentioned in like a lecture I was probably found, I don't know, on YouTube or something, anyways, but that the posterior longitudinal ligament is one of the most highly like innervated ligaments and innervated by that center vertebral nerve, just like the annulus posterior 1/3 of the annulus fibrosus. So treating, sometimes the back pain might be coming referred, that axial back pain might be coming from that posterior longitudinal ligament and not just like a annular fissure. So that's when I really started thinking about this years ago, like, this that PLL is so important, and there's like fibers from the superficial layer that even kind of extend anteriorly, maybe even blend in with the ALL, and has such a kind of crucial role there with providing stability. So that's what I was thinking. When you squirt this stuff in the epidural space, what does it do? What does it target? And I think it helps the ligaments, not just the direct effect on the nerve roots. That's, yeah.
And then I think, the other thing that's interesting is that, we know that PRP is pretty antimicrobial. And, there's the one study looking at treating, chronic disc herniations with antibiotics and noticing some improvement in pain. Have you seen anyone talk about that, or any studies looking at the antimicrobial effects of PRP in treating the back?
It's something that I often talk to my patients about when we talk about like relative risks. They've had an epidural steroid injection, immunosuppressant. It's going to suppress hormone levels for 4 to 6 weeks, depending on the steroid that you use. So, and it's going to maybe potentially, you don't want to use it in osteopenic, osteoporotic patients, especially excessively, because it can affect bone mineral density. So rare risk of, AVN. Relative to the thing covered by insurance, let's talk about it. The relative to the thing covered by insurance, PRP, I always joke with my patients, unless you hate yourself, it's a it's a relatively low risk. It's your own blood product, and it's antimicrobial, and can provide longer, greater benefit according to some of the studies.
Excellent. The next question was from Alicia Carter. She's asking, do you use leukocyte rich or leukocyte poor for spinal PRP? What are your concentrations? What are your volumes? Do you use per level, and also for intradiscal versus transforaminal injections?
So I try to concentrate, like the intradiscal, for instance, the intradiscal studies. There have been 2 studies, one by Dr. Lutz showing like the 3 to 5-fold increase versus the greater than 10 increase in relative platelet concentrations compared to baseline. The greater than 10 showed greater improvements. So more platelets, more dose, higher platelet dose, probably more growth factors concentrated, better outcomes. Then there was another study, independent group showed that the increasing concentration, looked at R coefficient, all that, showing higher concentration was correlated to greater improvements in symptoms. So I think more is better. I try to concentrate really, down. I try to really minimize that concentration. So again, if I use like a 60 cc kit, and I try to go through the math in my head, but 54 cc's of whole blood, concentrate down to 4 cc's. I want to put about, unless I don't really need that much volume for some odd reason, but about like 2 milliliters uh, per transforaminal has a pretty decent spread. And when we're doing epidural steroid injections, that's about the volume that most practitioners use, most docs use. So that's what I usually do. And you can see that the contrast dye spreads pretty decently, one level above and one level below about. So that's what I use there. I try not to compromise the concentration. When it comes to cervical cases, I'll use volume. I'll go up to 3 cc's, sometimes 3.5 cc's, depending on how high I need to drive that volume. I do only interlaminar approach in this cervical spine. I don't do transforaminal. I do transforaminal epidural steroid injections with dexamethasone, but I'm not doing the epidural PRP because of that radiculomedullary artery. We sometimes run into it. So I would love to hear. I'd love to know if anybody here does cervical transforaminal epidural PRPs here, but yeah, because there's a study, and this is also SIS, but basically there was a study showing that when you go in C7T1 and use 4 milliliters of volume, it goes up to about the C2 level. So thinking about that with like average patient, then I kind of think about how much volume do I need to drive it up. And if I can get into C6, C7, if on T1 sagittal MRI, I see posterior epidural fat, I'll go in at C6, C7. Generally don't go above that because that posterior epidural space really tapers, but C7, T1, C6, C7, and then think about the volume to get it to that area. And in the lumbar spine, you want to make sure that I try to see that contrast dye cover that posterior epidural space where that disc herniation is. Intradiscals, it depends on the disc. Lumbars, so I mean, it's amazing to me that some of the studies that we see, especially with the Endoret system, the PRGF, and they use like 3 cc's of volume. I go, again, call me chicken, but if I highly concentrate the platelets, I'll do 1.2, 1.3 cc's of highly concentrated platelets. I don't need to, overinflate it. But and I use the tiniest amount of contrast dye because I don't want to fill the disc up with contrast dye. I'd rather fill it up with concentrated platelets. So just where you see that you have like a flow in that nucleus pulposus, I don't even need a whole cloud, but just the tiniest amount, because I know when I push and there's the extension tubing and that additional whatever 0.2 mLs that's in there that has contrast dye, it will give me plenty of contrast dye in there, and then we want to fill it up with the platelets. So that's about the volume for lumbar discs. Thoracic discs respond really well too. That can be like 0.8 to 1 mLs, depending. The discs are smaller as you go up the spine and are larger lower because of the appreciation required. But you guys know it's more support, more weight bearing, more torso mass so they're bigger and smaller as you go up. So cervical discs, you could do 0.4 mLs. I don't do a lot. I'll use a 1 cc syringe, and I don't even fill it up. I don't even fill it up with contrast dye. I just make sure that I'm in the center of the disc, and I do ultrasound assisted fluoro guided approach to kind of like going deeper to a stellate ganglion block. So you're getting past it, avoid the carotid sheath, and you can slip into the disc and then flip to fluoro.
Outstanding. Thanks, David. I mean, I think that there's a lot of great information that you shared with us. I also see we have Mike Carlson on, our president-elect. Mike, did you want to say anything about some of the upcoming events kind of going on, or any questions for David?
Well, first of all, I'd like to thank David and you too, John, for another excellent presentation. I mean, it's very insightful, very helpful. We have a good turnout. And as Amy had mentioned earlier, we've got a workshop next month in Michigan for extremity work. We've got our Roatan mission coming up. I believe that's in October. And then we've got our annual conference that we've almost finalized in March. And so, check on the AAOM website and check it out, and would love to have you. But thanks for everyone for coming, number one. But number two, David, what an excellent presentation. Very, very well done.
Thank you so much. I'm honestly flattered and honored, especially following that. I'm the one usually watching, so this was John asked me. This is great. Thank you so much.
Thanks, David.
Yep, you did a great job. You're doing great work, so keep it up. And I think the other thing that we want to invite everyone to do is follow us on all of our social media channels. We want to continue to try to put good information out and good content out, especially kind of doing these lulls where, we're not going to go into all the conferences like we do at the beginning of the year. So if there's information or certain, content or certain things that you want to hear about or see on this channel, please don't hesitate to send us a message to the website, reach out to me individually, and we'll try to kind of make sure that we get good content that everybody wants to see and hear. I think that, we are pretty much done for the day. We'll let everybody go a little bit early. And we will be sending out an invite shortly for next month's topic once we kind of get that finalized. Everybody have a great evening. Thank you guys for your attention, and thanks for tuning in.
Thank you, everyone. Have a great evening.